Hey everyone, welcome. It's Dr. David here from El Paso Manual Physical Therapy. Hope you guys can hear me. Will you guys just give me a thumbs up that you can hear me? Because we were having a little bit of sound issues. Um, if you guys can hear me, I think we're good. What we're going to be talking about today are the 5 best exercises for painful bone-on-bone knee arthritis. Specifically, I'm going to hang on bone-on-bone knee arthritis because we did some research a while back, and over half of the members in our knee arthritis were found to be bone on bone. Like they were told, they reported to us that they were told that they were bone on bone, as they were told by their doctor. So they went to their doctor, the doctor diagnosed them, and they were told that they had bone on bone osteoarthritis in their knee. So we're going to talk about how it's diagnosed, what the treatment options are, and then I'm going to get into the exercises. So in case you're watching the replay or you want to just get to the exercises, I got to tell you I'm going to talk a bit before because it's important that you understand this because I was doing my own research for this in the are we getting sound? Yeah, we're good. Because I was doing my own research for this in the bone on bone topic. There's not much information out there except for a scale that the doctors use. The ones that they'll tell you about, like when they say you're stage 1 or stage 4, it goes up to stage 4. And I'm going to explain all that in detail to you guys today. And I want you guys to get ready with your questions. And then we'll talk about the exercises, the treatments that are best for this situation. And what I want to just tell you right now before we get too deep into this is you can avoid knee replacement surgery almost every time, even if you've been told that you have bone on bone knee arthritis. So before I get into all that stuff, who's here? Who's joining us right now? I see some people chiming in on the chat here. They're commenting. Where are you guys from? Caroline Shipsy's here from the UK. She's always here. Thanks for showing up here, Caroline. Steve Drake is in Grand Prairie, Texas, 103 degrees. Whew. We had a cold front come in El Paso, and we're like 93, 94 degrees right now. So we're cooling off a bit. But normally we're at your temperatures. Cindy Night King, it says, good afternoon from Odessa, Texas. It's finally warming up out here. Hi, everyone. Glad that you're getting some heat. Nice babies. I love the baby pictures. Adma Flower says, good afternoon. Good to see you, Adma. Fantastic. Julie Parker's here. Julie's a regular. Hello from Sydney, Australia, in the wee hours of the morning over on the other side of the planet. D, I can hear you. Thanks, guys, for letting me know. We just always want to make sure everything goes smoothly here. But as it is with live streams, as we are live right now, there's always little hiccups here and there, but my team is awesome at fixing all that. Kit Kat says, hello, Dr. David from Yorkshire in UK. We have 2 UK people here. Fantastic. Who else is here? Dr. Lyons is here from Los Angeles. Our Dr. Angelino is out there. Thanks for joining us, Dr. Lyons. Looking forward to everybody's questions, comments. Steve Drake says, I had one TKR, knee replacement, rolling replacement, and the other one is bone on bone. Oof. Hopefully we can help you out. Hopefully we can help you avoid the second knee being done, if it's possible. Quilting Mama says she's in Michigan. Thanks for joining us from the north. We're down here on the southern border. You guys are on the northern border. D is in Florida. Fantastic. You guys, that's the place to be this time of year. Nice beaches. It's beautiful out there. Jeanette says she's in Aztec, New Mexico. That's our neighboring state. We're probably not too far away from you. I'm not sure where Aztec is. I've not seen that one on the map. Jane says she's in Brighton, Ontario. I can only get to exercise 3. Oh, hopefully ask some questions here, Jane. Maybe there's something we can help you out with. Thanks for coming in from Canada, though. That's awesome that you're here. Who else is here? We have Matilda from New York. New York's here. Got the East Coast checking in, Florida and New York. Vilma says, Dr. David, thanks for all your help. I'm back to work now. Congratulations, Vilma. Glad you can get back to work. From Torrance, California, on bone, but doing well. Awesome. You see what I mean? Like this can improve. And I know doctors are waiting in the back in their offices are saying, just wait, it's only going to get worse. No, you fix the imbalances, which we'll be talking about how to do that today. You can maintain your knee health even though you've been diagnosed with bone on bone. So congratulations to you, Vilma. Great job. We got a 2-part comment. Mina's here. She says, hello, Dr. David. I've got a question regarding quads. So I feel that my quads are very dominant, but not strong at all. Oh, this happens all the time. I love this. Glutes were literally inactive before, but now I can feel them. What should I do about quads though? Great question, Mina. Um, this happens. So, I talk about the muscle imbalance, meaning the muscle imbalance that causes knee arthritis and other problems in the knee. And the imbalance is that the quads on the front of the thigh are usually too strong. And I usually say too dominant because, and I don't explain that all the time, but I'll explain it because it pertains here. Relative, so I'll say the quads are too strong slash dominant relative to the glutes. And then I also follow up with often people can't even fire their glutes. It sounds like you were in that situation, Mina. Now that your glutes are active, good. You're one step closer. And what you're saying is my quads aren't strong, but they are definitely dominant. That happens so much. So when I say strong, you have strong dominant quads, it may be that you literally have big quads and you're very strong in your quads, and that's the biggest muscle on your leg, not the glutes. But it may also be that you have small muscles. You're not that strong, but when you go to do some movement that should require you using your glutes, you dominate the motion with quads. So, like if you go stand up out of a chair or sit down into a chair, you go walk, it's more quad activity, not necessarily that it's the strongest muscle, like force generating muscle, it just takes over more. Usually, the dominant muscle is the strongest muscle because it just gets the most reps, but it's possible that you're not that strong overall. You may not consider yourself to have very strong quads, but it is the dominant muscle. You may not consider yourself to be a very strong person, but you can still have strong slash dominant quads relative to the glutes. So the position that you're at in right now, Mina, it's a normal position. You're in the middle of it. You figured out that your glutes were not active and they need to be more active. And now you're just dealing with shifting the muscle imbalance to where if your quads are very strong, your glutes weren't even active, at least you got them to turn on. Now you can begin to work the glutes and get them as strong, if not a bit stronger than the quads. And so this is the part where it just takes time. And how much time depends on how severe the imbalance was for you. And it's hard for me to give you a specific, like 2 months, a year, 6 months. It could be any of those ranges. What I would focus more so on, this is key, is that you're making consistent progress. And even before that, if you want to take it a step back, is just do the work consistently. If you're doing the work to activate your glutes, if you're using them in your walking, if you're being conscious every day, multiple times a day, probably every hour, if you're conscious about using your glutes more, then by default you'll put in the work to get your glutes stronger, and you should note that there's progress week to week and that imbalance is starting to go away. Some people it takes a few weeks, for some people it takes a few months, and others more than a year. I can't tell you exactly when that's going to happen. But I love that question, Mina. Good job. That helps you. Joan is here from Toronto. Fantastic. Another Canadian. We got breathing space. I remember breathing space in Miami. Oh man, all you Floridians are here. It's great. Who else is here? William Scott. Hi, Dr. David. Hi, David. Bill Scott in Falfurrias, Texas. I haven't heard of that place. Your leg swings advice has been very helpful. Great. I attach a 5-pound weight on each ankle when doing it. The relief is wonderful. I do it 10 minutes, 3 times a day. Great. I'm glad that that's helping you out. That's awesome, Bill. Fantastic. Who else is here? New visit here, Rochester, New York. That's Sewell. Sue Lewis. Great. Thanks for joining us from Rochester, New York. That's fantastic. More New York people. Who else is here? Maxine, GA from Yonkers, New York. I had meniscus surgery about 7 weeks ago, still having jabbing pain in the inner side of the knee, especially after sitting/driving. How long should that last? Oh, no, that's tough. My heart goes out to you, Maxine, or GA, I'm not sure what to call you. The meniscus surgery takes a long time to recover from. I mean, it's cartilage surgery. It usually takes several months. The doctor will tell you, "Oh, you'll be fine in 2 months," sometimes even 6 weeks, 4 weeks, depending on what procedure was done exactly. But I find that when I work with patients who have had a meniscus surgery, I don't work with them very much now, but I did a lot early in my career. Um, it was more like 6 months or more, the better part of a year. I mean, they're back to doing things. They're still getting pains like you're describing, Maxine. And so, my best advice to you is go much slower than what they've told you to go. Cut all the expectations down in half. Take twice as long to go through your rehab because it's cartilage rehabilitation and it just moves slower. So they tell you you should be on your feet in 2 months, it should really be more like 6 months, 4 to 6 months, something like that, like 2 to 3 times as long. Let me be more specific with you here. Uh, you need to slow down. Offloading is gonna be a better chance. At this point, if you're done working with the doctor, I would go through something like our meniscus recovery program, because you probably need to be offloading, you probably need to be working on your glutes, you need to be reversing the pressures in your knee joint, and that's what's gonna fix this problem. There's a chance you could have a tibial shift as well. So many things to fix. Go take a look at our meniscus videos on YouTube. This is a situation where you would benefit from it for sure. Jean Pierre is in London. Oh, awesome, UK. Dr. David Jean Pierre from London. Thanks for joining us, Jean Pierre. I'm not sure how to say it. I'm so sorry. What's next here? We have Catherine. Hi, Dr. David. I heard someone say that if our muscles are not being used appropriately, one of our legs may get shorter. One of my legs is now shorter. That was not the case before the accident. Um, I wonder how what the context or what they were thinking exactly, that person, if it was a medical person or not. The actual bones on the legs may not will probably not get shorter. That's not usually gonna happen. I've not heard of that ever happening. What's more likely to happen, let me show you on the skeleton. If you have muscle weaknesses, I'm speaking in general terms here, because muscles put tension on bones, where they attach to the bones, it can shift the way the bones move. So if you have a general weakness on just the right leg, it's not gonna actually shrink your bone sizes. What's more likely to happen is, especially up here in the pelvis, this pelvis bone can shift up or down or in or out, and that shift may bring your leg up with it. And down at your feet can give you the appearance of one leg shorter than the other, or one leg longer than the other. It's a relativity thing, like, you have to think of which one you're measuring. From my personal experience, that's what I often see, especially after some sort of traumatic accident, like a car accident, a fall, some sort of sports accident. People will get shifted pelvises, and then one leg will be longer than the other. And very often, it's correctable pretty quick with hands-on techniques. But it comes back if you have muscle weaknesses because the muscles can't hold your bones in place. That's what's key here. So I hope that helps you out there, Catherine. All right, guys, let's get into the lesson here today. I'm gonna talk to you guys about the diagnosis part first. So let me hang on that section because how you guys get diagnosed is for bone-on-bone knee arthritis is very critical. You have to understand what's going on in the doctor's brain, and so my hope is to convey that to you. Because imagine the picture. You walk into the doctor's office, of course, set up the appointment, your knee's hurting, you're suspecting you might have knee arthritis. You go to your appointment, the doctor will then do something very important. They'll take a history, so they'll talk to you, and they're getting to know you. And you know, prior to this, they're already getting your age as well. As soon as they know your age, as soon as they see that you're over 50, and the older you are after that, 60s, 70s, and beyond, they're already thinking, "Oh, this person has arthritis." So they're coming in with the assumption that if you have a knee pain and you're 50, 60, 70, they're thinking arthritis is gonna be a high probability here. Then they're gonna talk about your history. They're just gonna ask you questions. They're gonna say, "When does your knee hurt? Does it hurt in the morning? Does it hurt with certain activities?" And if you say key things like, "Hurts going up and down stairs, hurts if I've been on my feet too long, and then hurts first thing in the morning." And there's certain key words that you might say too, like, "I have stiffness in my knee when I wake up in the morning," or, "If I've been sitting for a long time, I feel like I have to loosen up my knee and lubricate it or warm it up to get going." then I feel better. Those are the telltale signs of knee osteoarthritis. So they're already thinking, just based off of this, without even doing an X-ray or anything else, they're already diagnosing you just based off of that information. That is how it is diagnosed. Okay, now this information, all the talking they do with you at the visit, and then your age is then put together with an X-ray. So very often they'll right after they do that, they'll send you into an X-ray. Sometimes they'll do an MRI, but those are way more expensive and take longer to process. X-rays could be done same day, and within an hour, you can get the results. And then they'll put the X-ray up on a computer monitor, or if they do it the old-fashioned way, they'll have the light box where they have the films and everything, and they'll look at your X-ray. And what you have to realize is the way they take your X-rays, when we're talking about bone-on-bone knee arthritis, they do it with you standing. So I have a picture to show. Oh, are we talking about the helpline real quick? Guys, we have the helpline open, so there's a phone number, 915-200, 4159. If you guys have a question, I'm happy to help you guys. Yeah, let's do the one below that. Yeah, so this is what it looks like when you take a standing X-ray at the doctor's office. You're standing in front of that pad, they have the machine pointed at you, and then they'll take the image there. So go ahead and take that one off. So you'll often be standing. Sometimes they might do it lying down or with your knee bent. They'll do different angles too, because sometimes they'll wanna get a picture of the kneecap surface against the thigh bone. Depends on how thorough the doctor wants to be, but the classic X-ray is gonna be that one that I showed you right there where you're standing, and they just take a straight on shot of both knees, and they'll do both knees very often to compare so they can see what both sides look like, right? So they'll do the X-ray, then the doctors are using a staging system. It's called the Kellgren-Lawrence knee osteoarthritis staging system, or arthritis staging system. Highly studied, and there's 5 stages. It starts with stage 0, and then it goes up to 1, 2, 3, and 4, with each one getting worse and worse. And if you're grade 3 and 4, I believe, my notes here. Yep, that's where you have the space reduction where they're telling you have bone-on-bone arthritis. So let's start looking at these Kellgren-Lawrence images of the X-rays. Let's start with stage 0. Stage 0 looks like this. This would be a normal-looking X-ray. This would be a healthy person. They don't have any signs of arthritis. That would be a 0. Then if we go to stage 1, what you'll see here is the beginning signs of arthritis. It's so subtle that they use the word doubtful. They actually would diagnose it as doubtful osteoarthritis. Maybe there's a bit of arthritis. What they're looking at is the edges of the bones. Let me see if I can get my hand in the right position. Like right here on the corners of the bones, they're looking for little bone spurs or thickening on the layers of the bones, close to where the joint is. Then if we go to Kellgren-Lawrence phase stage 2, here you can see a little reduction, but now you have sharper corners on the end of the shin bone, and yeah, there's 0, there's 2. So you can see the comparison there. There's sharper corners on the bones. And if we at stage 2, by the way, is where they call it mild arthritis, because here they're more definitive that you have signs of arthritis. The bone spurs are more visible, and you might be getting sclerosis or thickening of the bone. It shows up whiter on an X-ray, like brighter on the X-ray rather than darker. If we go to 3, this is where you have noticeable reduction in the joint space. The joint's being squashed now, and it's obvious. They'll call you stage 3 at that point, and they'll say, "This is bone on bone." And as soon as you're stage 3 or 4, they're gonna say you probably need to have a knee replacement, but they connect it with your symptoms and how you're feeling today and your decision to do it, because this isn't elective surgery. It's not an emergency surgery. It's elective. You decide when you wanna do it. It's not a life or death situation. Now, by the time you're stage 4, show phase, Kellgren-Lawrence 4, now it's severe. You can see the edges of the bones are a little more, thick. The corners, like, right where are we? Oh, this way. Right here, the corners of the bones, they're more, um, there's, like, a little overhang on the top of the shin bone, on that right side. That would be a bone spur. So this is where the doctor's telling you it's severe. You you need to get a knee replacement, it's bone on bone, and this image, this is the part that I want you guys to take away. You can take it off. This is where the emotions peak for you. If you guys have been there, you know what I'm talking about. The doctor's showing you the X-ray, and for the first time, you're seeing an image of what the inside of your knee joint looks like, and you're connecting it to the pain that you feel, the swelling, the stiffness, all those discomforts that you have, and potentially the fear of a surgery. And you're probably remembering this moment vividly and what the doctor looks like and what they're saying to you. And when they say the words, "You might need a knee replacement surgery," or "You should have had one last year." You're overdue for one. They'll say different things like that, and when they connect it to this image, it often leaves people feeling like there's no other choice, and it's just an inevitability, like it's going to happen. Maybe it flares down for a bit, but then it flares back up, and you're just thinking that it's only gonna get worse, and that is not 100% true. There are situations, a lot of good situations, where it will improve. Your motion will get better. Your swelling will go down. The stiffness can reduce, even go away. The symptoms can improve despite what your X-ray looks like. And this is research backed. Like, they're showing it in research that your X-ray doesn't always line up with your symptoms. Yet the doctors are making diagnoses and recommendations based off these 2 main factors. So ask questions, comments. If you guys have had that situation, this is what I would love. Let me take a poll here. Which of you guys, or not which of, just comment on here that that's your story, that you were told you needed a replacement, like you went to the doctor, they told you were bone on bone. I would love to see how many people who are watching right now are dealing with that situation. While you guys do that, let me take a call. We have Barbara, in Iowa, who's got a question about the massage gun. Hi, is this Barbara? This is Dr. David. Hi, Barbara. I'm doing well. How can I help you?
My question is pretty easy. So I watch your videos all the time, and the one on the massage gun,
Uh-huh.
I know how you're supposed to use it. But when it comes to using it on my upper thighs,
Okay.
both of them are really tender, and I don't know why they're tender.
Yeah, that happens. That's
Oh,
probably an indication of where you need to be using the massage gun the most. So when you say it's tender, can you put the massage gun on it, or is it too tender for that?
yeah. Oh no, I can put it on.
Okay, fantastic. The reason why those muscles are so tender when you put the massage gun on them is probably because they're overworking. They're being overused. So just like if you were to go exercise a lot, let's say I
Yeah,
gave you a weight for your hand and I said, bicep curl that weight like you're doing, like you're just bending and straightening your elbow over and over again. If I said, Barbara, I want you to do 1,000 reps today, you'd probably be pretty sore tomorrow. And
yeah,
if you poke that muscle, the bicep muscle, it would be tender. Now, what's going on with those hip muscles, those top of the thigh muscles, is they're probably being used more than they should be, likely because other muscles aren't being used as part of the muscle imbalance. So they're getting 1,000 reps at, like, the analogy that I gave you with the bicep. So they're just gonna
yeah.
always be tender until you switch the muscle use and you get the glutes to work better. Does that make sense, Barbara?
Yeah, yeah, that makes perfect sense.
Yeah. So in the meantime, the massage gun is designed to just tenderize those muscles, get them to relax a bit so that you don't overuse them as much, but you still have to go through the work of learning to use right muscles and getting those glutes stronger.
Okay, okay.
Yeah.
And I also wanted to comment. I bought yoga clothes by
Oh,
your
great.
recommendation.
Yeah.
I absolutely love them.
Glad you're enjoying them. Yeah, those can
Yeah,
be
yeah,
helpful for the right person.
yeah. You've given a lot of great recommendations. So
Oh,
thank you, Dr. David.
of course, Barbara. I'm glad I could help.
Okay, bye bye.
Bye-bye. Thank you.
You're welcome.
Oh, Barbara's cute. I love it. All right, we got lots of comments saying, "Yep, I was told that." Me, going back to the bone-on-bone arthritis thing and the story of how you get diagnosed. I was doing a lot of research prior to this video, and I even saw a video. There's videos on YouTube training healthcare professionals how to diagnose knee arthritis, and I love seeing them because it's pretty much what you would see if you guys go to it. There was even one showing Leslie Nielsen, a famous actor who did, like, all the Lethal Weapon movies. If you guys go check that out. Is it Lethal Weapon or Naked Gun? Naked Gun, sorry, I'm thinking of a different guy, a different movie series. Caroline says, "Not even bone on bone, but, told I needed replacement. Pain was from a torn meniscus." Yeah, I think they over-recommended it quite a bit. Doctors over-recommend, in my opinion, the total knee replacement surgery. And I said they're recommending it usually for stage 3 and 4, but I've heard many people come and tell us they're stage 2 and they're recommending a knee replacement surgery. And I don't know the full picture. I'm not talking to everybody in detail. Sometimes just do comments like this. But it doesn't surprise me because the perceptions, this is important for you guys to hear too when talking about the diagnosis, because the perceptions from many doctors, surgeons, general doctors, is that this is an inevitable problem. In other words, they'll tie it to age. They'll say arthritis is an age-related problem, which I disagree with completely. So then they'll say, well, you're not much of an exerciser. You don't look like much of, they'll make judgments and build perceptions about you, and then skip the exercise and therapy and just say, let's just go for the knee replacement because you're probably going to go there anyway. You're going to end up there anyway. All paths kind of lead to knee replacement, is how these doctors think of. Some of them think, well, I've seen therapists, physical therapists, hurt knee arthritis patients. And so they're afraid to send their knee arthritis patients to the physical therapist because they're like, well, all the clinics in the area that I send people to kind of make them worse. And that's because they're working out the wrong muscles. They're not trained to help fix muscle imbalances. Some of you guys might have been through that too. AZZ says, I've been told I need surgery 5 years ago today. Azza from Egypt. Hopefully you're doing well. Hopefully you're thriving. That's my hope. Who else is commenting on here? D says, I am bone on bone with bone spurs, and doctor told me I am overdue for a knee replacement. I am walking with a limp and can't bend my back leg when I walk. Painful. Oh, I hope you're offloading. I hope you're doing some offloading, D. Let me know if you are, please. Firm believer says, are those x-rays showing a tibia shift? They probably do show it, but I don't think the doctors are even aware that it exists and that it's something that's fixable. What firm believer here is talking about, let me get my model. I have videos on YouTube, and I talk about this a lot in the program as well, in our knee arthritis program. Let me show you the knee. Here's the kneecap, and then the thigh bone and the shin bone, and a tibial shift. This is the tibia here, the shin bone. It can move sideways that way or this way. Usually it moves this way from my experience personally. And you can see the edges of the bones right here, the edge of the thigh bone, then this bluish thing here is a meniscus, and then the edge of the shin bone, it'll shift this way. And then you're operating from that position, and that can be painful, and the doctors aren't even aware of the tibial shift. So there are cases where people have a tibial shift. They see our video. You can see the comments on the videos. People are like, "Wow, I got instantaneous relief," or "How to do it a few times. Did it for a day or two, and then my knee pain dramatically reduced." And it's often because there's a tibial shift present. It's not an age problem. It's a mechanical problem. So that's awesome. Who else is commenting here? I wanted to see some of these comments that people are saying that they got told they went to the doctor. Steve Drake says, I was told in 2002 that I needed a TKR for both knees, but that I was too young at the time for surgery. Finally had a left one done last August and the other one done soon. Not a death sentence. Yeah. Yeah, for the right person, let me talk about the other side of it. A knee replacement can be helpful for the right person. There's risks involved. That's why, I think it's overdone, and you have to be careful. And doctors are considering the age as well, because the reason why they're considering your age is because the current knee replacement have a certain life expectancy. Some will last 10 years, some are 20 years or beyond, depending on how the technique is done, what parts are used, if it was cementless versus non-cemented. There's a bunch of details on how they do this, and so a doctor will factor that in when they're making recommendations based on your history and X-ray. Sometimes that's why they'll say, "Oh, you're gonna be too old if you wait," or "You're too young, you need to wait longer." Like, they're thinking about those parts too. But what if you just don't even have to have it? That's what I the space I like to live in. What if you fix the root problem? What if there was a tibial shift that you could correct on your own or with some help and then work out the right muscles? It's not an age-related problem. That's what the mainstream medical field likes to, push you in because that's their training. Alright, so let me keep going here. Let's talk about the muscle imbalance just a bit because that's what's missing here. Muscle imbalance. If you've never met me before, this is your first time watching, this is an important thing that I talk about a lot, and if you've seen this before, you need to get this straight in your head in case you think you have it and maybe you don't or you're a little shaky on it, this is critical. When we're talking about knee arthritis, I'm gonna tie this to bone-on-bone arthritis here in a second, and that standing X-ray they like to do. You have muscles on the front of your thigh right here, they're right here, and they connect to the kneecap. These are your quad muscles right here. Then you have hip flexors that come up to the hip, and on the back, you have the hip extensors, the glutes, the butt muscles, and you have hamstrings. The key muscle imbalance that I'm talking about that causes knee osteoarthritis, bone-on-bone knee arthritis, is when your quads on the front of your thigh and the hip flexors, mainly the quads, are too active, too dominant, and likely too strong relative to the glutes on the back of the hip, the butt muscles. When that happens, then what begins to ensue is when you stand up, when you go get up out of a chair, when you sit down in a chair, when you walk around, you tend to use these muscles on the front of your thigh. And if you do that over and over again as the weeks, months, and years, decades pass, then these muscles get all the reps and they get stronger and stronger. And that increased strength ends up causing the muscle to tone up. And when it tones up, it literally will pull a bit. It contracts just at rest. It's got a higher contraction, it's more firm, and it yanks the kneecap up and it yanks the shin bone up because of how it's connected to the shin bone. Let me show you on the other model. Here's the right knee. This is the quad tendon. There's the kneecap, so it pulls the kneecap harder against the thigh bone, and then the connection goes all the way down to the shin bone, so it pulls the shin bone up harder into the thigh bone, squeezing the joint, causing a bone-on-bone appearance on an X-ray. If all this is compressed, so you have the muscles pulling the joint together, and then on top of that, when you take the X-ray, you're standing, which is reasonable because you need to walk and stand, but they're just taking a bad picture, which is exactly what an X-ray is. It's a picture. And so if I took a picture, if I got a piece of glass and I pressed it against your face, just like this, press, maybe another time. If we if we had a piece of glass and I just pressed it on my face and smeared my face on it, I would look like this, but I don't usually look like this. I I look like this. If you wake up first thing in the morning and you had your face on the pillow, you're not gonna look your best. You need a few seconds to fix yourself up. It's the same thing if your knee has been constantly compressed by a muscle imbalance. It's not the ideal picture of the knee. And that muscle imbalance is causing a lot of compression that is injuring the cartilage. It's literally squeezing the air, the life, the nutrients out of the cartilage. And if you can decompress it by fixing the imbalance, then it stands to reason that you could probably not have a bone-on-bone situation, or at least create an environment for healing that allows your knee to function normally without pain and without worsening the arthritis situation. That's what I'm talking about. That's what we fix with people. That's what our treatment approach is focused on, and it works pretty consistently as long as your knee joint isn't too far gone, which I'm not really sure where the limit is. The limit that I use, and we've been using pretty successfully, is that your range of motion is consistently bad. Let me tell you what I mean by that. If you're thinking, I don't know if you guys can help me. If you can pull your knee up to your chest, even if you have stage 4, Kellgren-Lawrence stage 4 knee arthritis, and the doctor said it's bone on bone and you should have had a knee replacement, but if you can pull your knee up towards your chest pretty well like this, and it's not too limited, what the rule that I use is 80% of the good side. So let's say this is my bad side and this is my good side. And if I pull my knee up here, I'm thinking, okay, that's about 80%, or that's 100% because this is my good knee. And then I bring my other knee up and I'm like, oh, I'm almost there. That's almost 100%, maybe 90%. 80% might be like not just slightly less. I mean, we're eyeballing it here on purpose because this is the best we can do on an internet live stream like this. You know, if you have some big limitations, if you try to bend your knee and you're like, that's all I got, and this one bends all the way this way, that's a big difference. But if it's more like that, that's better. Sorry, I'm looking at my feet now. Let me show you sideways here. So if I pull, you could do this lying down, by the way. If I pull my knee towards my chest this way, and this is 100%, and my other knee is almost there, but not quite, that's still good. That's improvable. Now, if we're talking about putting your legs straight, you can look at it from here lying down, and if your knee's sticking up a bit, as long as it's not more than about an inch, let me show you this way. So if I'm lying down flat and this one straightens out all the way and this one's no more than about an inch above, then I think we're good. And what I tell people is even if you're beyond the measurements that I'm giving you here, if you're sticking up more than an inch because your knee isn't straightened out all the way, if you can't bend your knee nearly as much, then you can still make improvements likely by beginning our program. We have phase 1 for free on our website of the knee arthritis recovery program. It's a 4-phase program. It's not the Kellgren-Lawrence stages. Notice I didn't say stages, I said phases. Because what I'm talking about are the phases of our program, which are the phases of healing. So phase 1 would be over here. This is the criteria that puts you into each phase. And associated with each phase, we have certain exercises that you would do that are only in this phase. There's exercises that are harder in other phases, but if you're in phase 1, then you should only be doing treatments related to this. And as you go into as you improve, then you should progress to harder exercises and so forth. But if you had those limitations that I talked about with range of motion, then it would be good for you to stick to phase 1. Now, hopefully you understand the muscle imbalance a bit. Ask questions if you don't. I'm happy to explain it a bit more. Answer questions or keep going here? All right. I'm gonna get into the treatment next. So what I recommend you guys do if you're diagnosed, if you haven't started treatment just yet, or if you're starting some treatment, you're thinking about what to do, if you just recently were told you have bone-on-bone knee arthritis, and this is your story, you need to understand the muscle imbalance. Rewind what I just talked about, understand it thoroughly. What will ensue next, what will happen next, is your doctor will make some recommendations for treatment. And the treatment recommendations are gonna focus on usually starting with some sort of medication, like some oral pain medication, you know, like an ibuprofen, naproxen type of medication. They might go a month or 2 for that, and then tell you to come back and let's see how it behaves. And what they're hoping, they're crossing their fingers and saying, "I hope this is just a flare-up and it goes away and you got another year, maybe 6 months, maybe 2 years if you're lucky." But what they're expecting is you're gonna get older, it's already bone on bone, it's just gonna get worse. That's what they're expecting. So then they'll recommend in 2 months or so an injection. And that's medication that they inject into your knee joint with the hope that it reduces inflammation and pain in the area. And if it's successful, 'cause sometimes it's not, you got a few months, maybe 2 or 3 months if you're lucky. On the long end, 4 or 5 months. And what they're hoping is that it resolves spontaneously because they're not fixing the imbalance, they're just treating the symptoms, they're just treating the pain. They're not making your glutes stronger, they're not teaching you to calm down your quads. Meds and injections don't do that, they just treat the pain, it's short term. Sometimes they'll recommend regenerative medicine, which is usually injections like your PRP injections, PRP, stem cell injections, and then there's other procedures out there like genicular artery embolization, genicular nerve ablation. So I can get into that if you guys have questions, but they'll recommend this stuff. But ultimately, what they're expecting is that you got this diagnosis at 65. They're saying maybe you got a year or two, and at 67, you're gonna be recommended surgery. That's the typical treatment approach. Hopefully, prior to going to surgery, they recommended PT, physical therapy. This happens fairly frequently. And what you'll see when you do that for bone-on-bone arthritis is they'll send you to the clinic, the physical therapy clinic. It may be attached to the doctor's office. It may not be. It could be a freestanding independent physical therapy clinic. It may be a government-run one. It just depends on where you live, what the situation is. But very often, the physical therapists at that clinic are great at helping people after a surgery, like after a knee replacement surgery for somebody who had bone-on-bone knee arthritis. But if you're there trying to prevent a surgery or avoid a surgery, what's likely gonna happen is they're gonna have you do the same exercises that everybody else with any knee problem is doing. They're gonna have you do quad exercises, like where you tighten your thigh muscles, walking, cycling, very basic exercises, and there's little to no instruction. Their favorite thing to do is grab timers. You hear timers all over these clinics. They'll give you a timer and say, okay, we're going to put you on the bike 10 minutes, and then they'll walk away and they'll come back to you because they have a lot of patients. They're dealing with a lot of people. And that's how those clinics are set up to run. They're good at helping people after surgery, but they're not great at problem solving and understanding the muscle imbalance. You need to find a specialist who can do that. They're growing. They're popping up here and there. Um, I hope that I've perpetuated that, but I even if I can't take credit, I'm happy that you got better anyway. That's totally fine. I don't care at the end of the day. But that's the treatment approach. Now, there is hidden gold in the physical therapy section, but it is not, there's no training. I was a professor in a physical therapy school, and I went through the curriculum. The state mandated the national, I forgot the accreditation body that determines what needs to be taught in physical therapy schools. I've looked at all that stuff, and it is focused on helping people after surgery. That's what the students are learning. So that's what most therapists know. Muscle imbalance training to prevent surgery is not a normal thing. All right, so then, do I keep going here? We go comments? I'm gonna talk about the 5 exercises next, but let's see what comments you guys have. What do you guys think so far? Bone-on-bone knee arthritis, diagnosing, the X-rays, the Kellgren-Lawrence scale. Azaz says, "My calf and shin muscle on the affected knee are getting slimmer and weaker. Any reason?" Well, probably because you're not using them as much right now. That's not a good thing. The calf and shin muscle. One of the exercises I'm gonna talk about is a toe exercise. So stay tuned for that one, Az. I think that'll help you out. Yvonne says, "I have osteoarthritis. When doing my knee exercises, my tibia hurts. Why is the tibia involved with knee pain?" Oh, well, the tibia is the shin bone. So here's the knee. And the upper part of the tibia is the bottom half of the knee joint. If you have any alignment issues like I was talking about, where the knee shifts sideways, it could tension nerves, it could pull muscles and tendons, and it can send pain down into the tibia. There's also like into the shin area. There's also a chance you might have like a sciatica type problem, a back issue. It happens very commonly with knee arthritis because the same muscle imbalances that cause knee arthritis also set up sciatica. So that happens all the time. Okay. Got several comments I'm gonna read all together and then answer on them. Steve Drake says, "To be clear, Dr. David, I've been doing your exercises for several years and it does help, but at some point, knee replacement is absolutely necessary. I'm that person. I still do your exercises daily." Okay. Lovely Jubbly says, why absolutely necessary? Then Steve says, to be able to walk without pain. Yeah. So this is it could be a situation where for you, Steve, your knee is so far gone and you're doing the right thing and seeing if this is going to be a possibility for you to fix the problem. And you've given it years. Um, I don't know exactly how you've implemented everything, and we can always reason that you could go deeper into this. You could, but ultimately, you're the person that's going to make the decision. You have agency. You can decide what you want to do, and you've determined that at the current situation for what you've tried, the evidence, all the stuff that's happened to you so far, that it's right for you. I'm okay with that because I can sleep better at night knowing that you know about the muscle imbalance and you've done the work to try to fix it. And if you feel like you still need a knee replacement, at least you're going into the knee replacement with better glute strength. And after surgery, that knee replacement is going to last you even longer because you're not going to put bad forces on it. So I'm okay with it. I'm good if you're at that point. And many of you guys, though, are probably not at Steve's point. You're thinking, I'm not that bad. I have good days. Maybe at some points I'm bad, but then there's points where I'm pain free. If I overdo it, it'll come on, but if I do my normal daily activities, I'm okay. Those are a lot of people, and that might be a great situation for you to avoid the surgery completely if you're told you have bone-on-bone arthritis. Love it. D says, "What is offloading?" Excellent question, D. Offloading is when you take pressure off of the painful knee, and the way you do that, let me show you, is with devices like this walker and crutches. Gotta get I don't think we're gonna get our borrowed crutch back. We're just gonna have to get a pair of crutches again. So ideally, I would have 2 crutches, and I would be walking around leaning on the crutch and picking up my legs so I don't put my full body weight on it, so that I can walk and not put pressures through my leg. That would take pressure off the irritated knee so that I'm not further irritating it. And you can do the same thing with a walker. Just go through like this. It's okay if you put a little bit of pressure. You have to figure out how much pressure you can take without irritating your knee. And ideally, would be even better is if you just get off your feet completely. When I talk about offloading, the the ideal for offloading is lie in a bed, recline on your couch, sit, don't stand, don't walk. Reduce your walking to an absolute minimum for a time so that you can allow your knee to flare down, to not be so irritated. But when you do have to walk, because you have to, right? You have to get to the bathroom, you have to do certain things that are important for life, for your responsibilities. When you have to get up, use one of these devices. A cane is another option, but the canes don't offload as good as the crutch and the walker. That's offloading. That's an early stage thing. We talk about it a lot in phase 1 of our program. Right, Maxine says, "I've been working on the glute exercises and knee stretches with some relief. Thank you. Should I continue to use a cane even though I'm 7 weeks post-surgery?" That's tough, Maxine. It depends on how well you're walking. It depends on how you feel and your doctor. If you had surgery, you need to be listening to your doctor. Let me make this clear for everybody. If you end up having a surgery, whatever surgery, whether it's a knee replacement, if you had an eye surgery, a surgery that doesn't relate to your knee, this stuff that I'm telling you to do needs to be run by your doctor, and your doctor will usually have some opinion on when you can get to exercise, when you can get to more aggressive physical activity. Which this isn't super aggressive, but I would just put it in that category for the sake of your health. Because if you had a cataract surgery, you shouldn't be doing anything for probably a week or two, even stuff like what I'm talking about. But if you had a knee surgery, the doctor's probably going to tell you you need to be off of it or doing certain things that they want you to do. Once you're cleared by the doctor and they've told you, all right, you're good to go, you need to come back and see me anymore, go ahead and do whatever you want to do. That's when it's time to do this stuff that I'm talking to you about here. That way you follow your doctor's orders and you make sure, because if they did a procedure on you, you need to follow what they said so that you heal properly. The liability needs to be on that doctor for following through with the surgery the way it's supposed to be done. I don't know what surgery you had done. But after you're cleared, then it's time to come over here if you still have problems, and let's help you out. So as far as the cane use, talk to your doctor first. The doctor says you're clear. Then it's a matter of, do you feel like you can walk without pain if you stop using the cane? Do you feel like your form is good, like you can use your glutes and you're not limping, whether it hurts or not? Because if you cannot walk properly with good form, then a cane might be appropriate at that time. Good question, Maxine. Firm believer says, how can I find a PT like you? How do I know if they look at muscle imbalances? Firm believer, it is difficult because there isn't like a clear certification or title that we have. I went through some specialty training, but I went through a lot of training, more than the usual specialist. And so um, my best thing is ask them questions, interview them, maybe look at the reviews if they have reviews on Google. Go talk to their patients too. If you show up to a clinic and you look around, this is the best thing you could do. If you look around the patients that are there, or even ask them, "Hey, can I go talk to the patients?" They might let you. In the waiting room, you'll definitely run into patients and just say, "What are you here for?" And if most patients are saying, "I had surgery," if at least half or more of them are saying, "I was here because I had a knee surgery, I had a shoulder surgery, a back surgery, whatever surgery," then that clinic specializes in helping people who have had surgery. And they're probably not gonna help you very well if you're trying to avoid surgery. Now, the if most people are saying, "Oh, I'm getting my back problem fixed, never had surgery, I'm here for my knee," then it's usually a better situation, but there's no clear situation. It's hard to tell you from believer with like how to find somebody like me. Another thing that we've had people do is show them our videos, show your therapist our videos, and sometimes they start learning from there. And this stuff's common sense. Like I'm not. I mean, I'm talking to you guys. Many of you guys are not healthcare professionals. Every now and then, somebody does show up here as a doctor or PT, and most people get this stuff. I'm talking about mechanics. Like it's straightforward. It just doesn't get taught in school. All right. Well, let's get into the exercises, guys. What are the 5 best exercises to do? I'm gonna detail them here for you guys, and I'm gonna kinda talk about the phases that they're in too. So number 1 would be a tailgate swing. You have knee arthritis, that's bone on bone, and it's hurting right now. Tailgate swinging would be number 1 thing to do, and this would be a phase 1 exercise. So I'm just gonna write P1, put in parentheses out here, and let me explain to you how this works. It's really simple and straightforward. You find somewhere you could sit where your feet dangle, and if you don't have a high enough chair at home, put pillows under your bottom. Stack 4 or 5 pillows, and you might need to scoot on top of them, and your feet just barely need to dangle. They don't have to be super high up off the ground. And then you're just gonna move your feet like this. You're gonna move your feet back and forth. You can move them independently or, together or opposite. It really doesn't matter. The point, what you're trying to do here is get some easy movement into your knee that hurts to circulate the fluid inside your knee. There is fluid in your knee. It's called synovial fluid, and that fluid carries important nutrients for your cartilage in your knee to heal. The thing is that fluid doesn't move unless you move your knee, but walking and doing more aggressive things is hurting you right now likely, and so this is a very non-aggressive way to get that fluid to move. Now, it's not enough to just do this for 10 reps or 30 reps. You need to be doing minutes worth, like 4 or 5 minutes worth, and it needs to be frequently throughout the day. Every hour is what I recommend people do, as long as it doesn't hurt you. And it shouldn't be aggressive to where you feel like your muscles are working, you feel like you're starting to sweat or get a workout. It should look casual. I mean, like, I'm talking to you doing this. You could do this talking to your friend, your family members, watching a show, having a meal, as long as your feet dangle. And even if your feet don't dangle, if you can get your foot on a slippery surface, like what I tell people who have tile or laminate floors at home, is put a sock on, and just slide your sock over the tile, over that smooth surface so that it's lower friction than if you had shoes on and it was on, on the ground. That would be tailgate swing. Start here. This isn't gonna fix the whole problem. This is just a starting point to get the irritation down. But if you have bone-on-bone arthritis, this is a good one. Somebody commented early in the live stream that they're putting 5-pound weights at their ankles as they were doing this. And I'm not against that. I don't think it's a terrible thing. I just think it distracts from the main goal. And if you find that you want to try this, you have ankle weights at home, and you want to do the tailgate swings with ankle weights, by all means, go for it. I don't think it's a completely bad thing to do. The issue is that I don't want you to be aggressive, and when you put ankle weights on there, it just adds momentum, and what I don't want is for your quads to begin to get tensioned and have to be pulled into the exercise in a more, intense manner. I don't want the quads to be activated more than they normally would be. So as long as you're careful with that, you don't feel like your quads are starting to get super warm and worked out, you can give the ankle weights a try. And the theory with that is that it's pulling your joints and putting some space in there. I haven't seen anybody mess things up that way. But I also can't tell that there's been a significant benefit to doing the ankle weights. That's why I'm not like pushing it on you guys and saying you got to do the ankle weights. It's up to you if you want to try it and let us know. So that would be the number one exercise. Number two is pretty critical. We need to get glutes activated. So glute activation, right? Glute activation exercise. This would also be a phase one activity. When I say phase one, I'm talking about our knee arthritis recovery program. So for somebody who's got knee arthritis, bone on bone, we're assuming that the quads are dominant, likely too strong, and they're yanking the kneecap against the thigh bone, and they're yanking the shin bone up against the thigh bone, so they're causing all this compression. And in order to solve that, what needs to happen is this muscle back here needs to wake up if it's not awake yet, and then work more and get stronger so that it calms down this one. It's a compensation. So if this muscle back here isn't doing its job, the thigh muscles are in a position where they say, I got you. I'll take over. I'll help you stand. I'll help you walk. I'll help you move around. But then it becomes a problem over time and it causes knee arthritis. So to fix this, we have to first tighten the glutes. The best place to do it is just sit down anywhere. Feet can be touching the ground, doesn't matter. And then put your hands on your rear and your backside, and then tighten your glutes. Make them tighten up and hold it. Relax your thighs. And that's the hard part, because what you might find as you're tightening up your glutes right now is your feet start to go up and your legs do this. When that happens, what that means is that you're subconsciously, you're unaware, you're tightening up the thigh muscles when you should be tightening up your glutes back here. Your knees should stay bent and relaxed. But if you try to tighten up your glutes and thighs activate, it'll straighten your knee out. Not good. That means your quads are being dominant. In standing, it will look like this. Let me tuck in here. When you stand up and you try to tighten your buns back here, these muscles try to squeeze. If that happens and you find that these muscles here squeeze too, this squeezes and this squeezes, that's not good. That means you're co-contracting. These muscles are firing together, and ideally what you want is only this one to fire, not this one. Now, to be fair and to be realistic, when you move, you're going to fire all your muscles. But what we're trying to do here, for the sake of fixing your bone on bone arthritis, is bias the glutes. So if you can confidently say that you tightened your glutes and your thighs minimally or hardly fired at all, then you're good. But if you can't confidently say that, if you tightened your glutes and you said pretty equal, or it's a lot more my thigh than my glute, or I don't even feel my glute at all, you're in bad shape. We need to fix that. Get us a drink. When you tighten your glutes, what should happen if you're doing this in standing is you should be thinking about slowly and subtly tightening your glutes up. Put your hands back there, because you feeling your muscles will help to get a good idea for how to fire these muscles. And then think about just tightening these up. You're going to feel like you're pushing your hips forward. That's okay. It might even cause your knees to bend slightly. That's okay too. Because think about it. If your quads are firing, it's going to make your knees want to straighten and lock out. So if your knees stay a little bent, that's actually helpful to keep your quads relaxed and make these muscles work back here. Then what I want you to do, once you can figure this out a bit. You might be stuck here for a while, by the way. You might just be playing with that motion of trying to tighten your glutes and not tighten your quads. Take as long as you need. It might, for some people, it takes days or weeks. Once you can get it, then what you need to do is hold it, hold the muscle contraction in your backside. Make your butt just tighten and hold it. 10 seconds is what I like to do, because you can hold it for 10 seconds. It's enough time for your brain to send signals down to the nerves that connect to your butt muscles and strengthen that connection, that nerve to muscle pathway. And that is critical. It's critical because later on, when you're in later phases of our program, right now we're still in phase one. When you get into the later phases, you're going to have to do other exercises. Think about it. In physical therapy, when you go to that physical therapist who specializes in helping people after surgery, they're making you do bridges, potentially squats, potentially going up and down stairs, other glute exercises. And if you cannot confidently activate your glutes without your thighs taking over the motion, it's a failed exercise and you're feeding the problem. Because if every time you go to try to activate your glutes, but it's quads activating, because you're trying to do a phase 2, 3, or 4 exercise, then you're just strengthening your quads more, which perpetuates the problem. It just pushes your kneecap down harder and pulls your shin bone up harder and just squashes your knee joint worse. This is why people end up going to therapy and then they say, yeah, I kind of got worse there. I did everything they told me to do. I was following the timers. I did all the homework they gave me. They gave me a printout and I did it religiously. I did extra even, and it got worse because you're working out the wrong muscles unknowingly, and they don't know either because they don't know what muscle imbalances are. They don't clearly know what they are, like I'm describing them to you here. So glute activation, guys, is a critical milestone for everything else to work properly after. If you don't nail this part down, you're gonna fail the rest. You're just doomed for failure. You need to stop and figure this out. All right, there's 2 other muscles that I want you to activate very well. Let me go into those next. All right, we got glute activation done. We have lower ab activation. Now we're talking phase 2. And it's a step up because if you can get your abs, let me make the connection here between the glutes and the abs real quick. So abs fill up the space between your rib cage. They attach to the edges of your rib cage here, and then they come down and fill up all this space, and they attach to the edges of your pelvis bones here. All that is abdominal muscles. Specifically, I'm talking about the lower abs. And the way you know where your lower abs are is if you find your belly button or where your belly button should be, then below that is where your lower abs are. The belly button is kind of the halfway point between the upper and the lower abs. So those lower abs that are down in this region, they connect to your pelvis bone right above the pubic area. That area is where you should feel your muscles working. The reason why it's important is because the glutes attach on the back of these pelvis bones, and so they need these bones to be stable for everything else to work. And when those lower abs activate, they yank up the front of the pelvis bone and they stabilize it. Some people who never work out the lower abs do work out their glutes. They hit a wall, they hit a limitation because they can't get their glutes stronger beyond a certain point because they're missing lower abdominal strength. Let's remove that limitation for you guys. The way that you do this, and seated again, earlier we were tightening up our glutes. Now I want you to suck in your abs. Put your hands there. It's always important to put your hands where the muscles are that you're going to fire. So my belly button's right here. I put my hands below my belly button, right above the pubic area, and then I'm sucking in. Let me show you what this looks like from the side, because you need to see my lower back here. So if you see my lower back right here, and I have a small curve in my back. If I sit up real straight, you can see a small curve. When I put my hands on my lower abs, I'm rounding out my lower back. See what I did there? It looks like I'm slouching, and I can feel my lower abs working. Now, this is how to do it in seated. Some people figure it out really well this way. You might find that you need to do it lying down. So I would lie down, bend your knees, and then another way to think about this is to put your hand under your low back where the curve is, right above your tailbone. If you push your lower back against your hand, like you're smashing that hand under you, you should feel your lower abs work below the belly button. And I want you to hold it there and think and connect your brain to those muscles. If you can get those muscles to connect and get them under your conscious control, now you've figured out how to fire your lower abs. If you're having trouble, a trick that I've used with people that works pretty well is to just rock your hips back and forth, like smash your hand and then take all the pressure off, stick out your butt, then tuck into your butt. All these different cues that we use to get people to do the motion where they flatten out their back and then fire the lower abs. In the medical world, you may have heard this called a pelvic tilt, a posterior pelvic tilt, where you're smashing your back down against your hand like this. And then in standing, the way that it looks in standing is you just stand normal. I'm showing you the side view again so you can see the small of my back, the little curve. If I do an anterior pelvic tilt, it's the same as sticking out my butt and increasing the curve of my back. That's the bad kind. That shuts off the glutes. But a posterior pelvic tilt would be forward hip thrusting and then kind of rounding out your back and doing a little bit of a slouch up top. That turns on the glutes very well, and it turns on the lower abs. You're going to have to think about it. You're going to have to think about connecting your brain to your abs. These exercises, oh, by the way, I like people to do 10-second holds, 10 reps. I'm giving you more concepts and exercises because that's where we start people off. In phases 1 and 2, it's about holds and doing this frequently. You have to shift your thinking about exercises from here's a list, do this 10 times, do 5 sets, and you did exercises and you have a routine that you go through, and that's what you did for the day, and it just takes up like 30 minutes of your day, maybe an hour. That is not how you fix arthritis. That is not how you fix a muscle imbalance. That's how you get fit and in shape. Once you don't have a muscle imbalance, then it is an exercise routine. But at the beginning, it's about muscle activation. We have to figure out how to activate these muscles so that you can get into those regular routines, but you're consistently firing the right muscles now. You're getting a much more efficient workout when it's time to work out. But you can't get there if you can't even turn on these muscles. This is what's missing in regular healthcare. This is why people end up having surgery. And it's completely possible to avoid it, even if you have bone-on-bone knee arthritis. I got 2 more points. Should I keep going, or do we have comments? All right, I'm gonna keep going, guys. Looks like you guys are absorbing all this. Ask questions. I want to see comments if you guys have them. All right, next activation we have to do is toe flexor activation. This one gets missed all the time by healthcare professionals. Keep messing it up. Hard for me to talk and write at the same time. Toe flexor activation. And the reason why it's important, it's also phase 2 exercise, is, let me bring the skeleton back in. Oh, this one's got the broken foot. Let me just use the other side. The toe flexors are what they sound like. It's the muscles that help to curl your toes. So we have a skeleton here, and you're thinking about these bones here bending downwards. The muscles that send tendons, the muscles that are responsible for curling the toes, they send tendons right in the arch of the foot, right in the big arch of the foot. When those muscles get weak, you don't have good arch support, because when those muscles are stronger, then it better supports an arch in your foot, which affects the position of your knee. I'll show you what I mean in my foot here, because I have flat feet and I've had to work on my toe flexors quite a bit. So if you see the arches of my feet right here, when I sit, I have arches. If I just relax and rest, it looks like I have arches. And then when I stand up, let me just show you my right foot here. When I stand up, if I'm not conscious of it, my arch just collapses down. It's very minimal. But if I use my toe flexors help you to curl your toes like this, and I work on these muscles and I can activate them properly. I'll show you what properly means here in just a second. If I can do that, then it can translate to when I'm standing, I can activate my toe flexors and I can raise my arch. You see that? I can do it on both sides. I can raise my arches. My feet are still in control, but now my arches come up. Now, if you zoom out a bit and you see what happens at my knees, when I raise my knees kind of come out. They have better support from my feet. So now we've gone through 3 muscle activations here. I'll show you more details on the foot activation here in a second, but we've strengthened, I've shown you how to activate glutes back here by tightening these muscles. I've shown you how to activate the abs. So glutes, abs, and then now toe flexors to get arch support. When you put all 3 together, you are creating stability below the knee and above the knee in key points that need it so that your knee joint is decompressed and it takes the normal pressures instead of abnormal excessive pressures that promote knee osteoarthritis, especially bone on bone knee arthritis. The way to activate your toe flexors, here's what I want you to do. So when you think about toe flexors, there's a bunch of joints that bend, right? They're just like fingers. Like they have knuckles just like fingers. And most people, when they curl their toes, they're curling these knuckles only, and they're missing these knuckles in their hand that bend right here. In the foot, those knuckles that are the equivalent of my knuckles on my hand, they're right in this area of the foot. So when you curl your toes, you should be able to see depending on your anatomy, you should be able to see some knuckles pop out kind of in this area right here. And you want to think about even the baby toe, the little 4th and 5th toes coming in. And what I'm doing here with my hands, you can see I'm pulling my toes down with my fingers so that you can make the knuckles pop out. Then what you can do, this is the exercise, is hold it and let off your hand and see if you can still maintain those knuckles popping out. And it takes effort. And I got to tell you, be careful because the first time you do this, you might cramp because oftentimes people have very weak toe flexors. And when they're going 100% to curl their toes, they all of a sudden get a cramp in the arch of their foot and it's not comfortable. So hopefully you haven't gone there yet, but be careful. The way that you can get around the cramp is go as hard as you can without cramping. So in other words, if you went 100% and you started to get a cramp, back off to say 90 or 80% or maybe even 50%, maybe even 10%. And you might need to hold your hand over your toes to get the joints to go all the way. Because if you're working your toes and those knuckles don't bend, it's just the end of your toes that bend. It's not enough. We need to get your whole knuckles to bend, then try to work them there at that right percentage for you, 30%, 50%, whatever it is. And over a few days, you should see that it improves, that you get better and better at it. That toe flexor activation exercise, super important. So I will say before I get to number 5 here, that glute activation solves 70 to 80% of the problem for bone on bone knee arthritis pain for a lot of people. They'll say, oh my gosh, I had a tremendous improvement in my knee pain. My stiffness got better. My knees don't hurt as much. The swelling's almost gone. But they'll say, there's still something there. I still feel it a bit. But we've made a massive amount of progress just activating the glutes and beginning to strengthen those. But that last 20, 30% comes from these two. When you strengthen your lower abs, and you get better efficiency out of your glutes, fixes a lot of back problems too, by the way. Then when you strengthen those toe flexors, it takes care of the bottom below the knee, the support from below the knee, and it allows you to get to that 100% resolution of the problem. If there's potential for you to do that, which oftentimes there is if you have a good motion. So these three key muscles are important to activate. So then you can begin to move into harder exercises that involve all these muscles to work at the same time. Notice I just wrote phase 1 and phase 2. There's 4 phases in our program. In phase 2 of our program, we're heavily focused on activating these muscles. And I'm going to show you one more phase 2 exercise that's pretty important if you have bone on bone knee arthritis. Number 5 would be glute walking. It's a phase 2 exercise. This is where it gets tricky. So you have to spend the right time and effort on glute activation, lower ab activation, and toe flexor activation because you're going to then put it all together in walking. And if you're watching this for the first time, you haven't heard me talk about this concept, your head might be blowing up. You might be like, oh my gosh, I have to do all that. I can barely get my toes, your tongue sticking out, just trying to get your toes to activate properly. It's okay. Take the time necessary to get those muscles working. This isn't something you do in a day, in an afternoon. This is something you gradually build on. And this whole process might take you a month or more, 2 months or 3 months. Right. So the way that you put it all together for glute walking is when you walk, let's talk about glutes first, and I'll throw in abs and feet. When you take a step, say I'm going to step with my right side right here, the right glute, as I bear weight onto my right foot, this muscle back here on the right side should begin to tighten up to push me forward as I take the next step. And as I swing my weight onto the other foot and I begin to bear more weight on my left foot, then my left glute, the opposite side, should contract. This right one should relax and the left one should contract. So said differently, as I take steps, tighten the side that you're on. Tighten and tighten. That's what should be happening with the glutes. Now, the abs are going to consistently be firing. So remember I talked about this posterior pelvic tilt motion that tightens up the abs and the glutes together? You should start your walk already slightly tilted, slightly activated in your lower abs. So just turn on the abs, then think about glutes, 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 alternate as you're walking with the abs consistently working. So that's the second layer. The third layer is now we're talking feet. When you bear weight onto that right foot, those toes should grab. You should activate your toe flexors, but without curling your toes under your foot when you step. You should just flatten out your foot so that you raise your arch so that when you bear weight onto that leg, your knee isn't collapsing in. It's staying supported. Glutes activated, abs are activated, and then you switch to the other side. Abs already activated. Now my left glute's working on this other side, and my arch on the left foot is supported as I take a step. Now, I just explained a lot, and you think to yourself, oh, I just want to walk down the hall, and it should take me a moment. But the fact of the matter is, walking takes thousands of reps, tens of thousands of reps potentially for you a day. Think about it. It's a goal for a lot of people to walk 10,000 steps in a day. That means you're doing 10,000 reps of walking. And if those reps are done incorrectly, because you're not using your glutes, you're not using your abs, toes aren't doing anything, going for the ride, then you're not walking properly. And those are thousands of reps where you're actually feeding into the problem because if you're not using these muscles, what are you using? By default, your body's just going to figure out other muscles to use, and it's usually the quads. That means you get thousands of reps using your quads to walk, and it just compresses your knee joint worse and worse. Those quads attach here, and they're just yanking the kneecap harder, creating a worse bone-on-bone situation against your thigh bone right here. And then this tendon that connects to the shin bone is just pulling and smashing your meniscus worse, and the cartilage on the end of the thigh bone worse, and knee arthritis is getting worse. That's why you see worse bone spurs, worse sclerosis, decreased joint space, because you take thousands of steps incorrectly throughout the day. This isn't taught. In regular physical therapy, all they do is they say, go walk on the treadmill. Zero instruction on what muscles to use. There's no offloading before that. So this process right here, guys, are the 5 best exercises for painful bone-on-bone knee arthritis. This sets you up. After you go through this process, then we can talk about more complicated exercises that they love to give you way too early. And we have a call we're going to take. Ken has got a back pain question in Las Vegas. Hey, Ken, this is Dr. David. How can I help you? Hey, Ken, are you there? Ken, are you with me? Hello, hello, hello. All right. Well, we'll maybe try again. Can't hear you, Ken. Can you hear me? Yep, I have all the settings on right. Ah, we must have got disconnected. It looks like it's like the call's connected, but I can't hear Ken. All right, let's go back over here and see what questions you guys have about all this stuff here. A lot. It was a lot. Hope you guys are hanging in there. Cami says, this is his technique that finally helped me with my low back issue. It will work. I walk like this all the time and I feel fantastic because of Dr. David. I love that, Cami. And a lot of people feel weird when they're doing it. They say, I feel like I'm walking like a robot. And really, you don't look weird. Like if you see yourself, you don't look that weird. Maybe the first, few times you're trying it out, but it eventually becomes more casual. You make it more simple. It becomes a normal way of walking and it feels good. It's the way our bodies are supposed to move. Glad that's helped you out, Cami. Fantastic. Lovely Jubbly says, is it better to do toe flexes standing or laying? It really depends on where you're at. If you are having trouble curling your toes and making those knuckles bend as much as I showed you, then not standing is probably the better way to start so that you can get that full bend because those joints just don't bend in enough people. Let me show you on the skeleton here on this model. This one's probably a better model to use. So these these let me get out of the way. These toes here will bend on the tips, but these big knuckles in the middle of the foot, those need to get to bend as much as they'll bend, as much as your body allows them to bend. Everybody's different in their flexibility. But once you can get those to bend and you're not cramping using the muscle well, then you can go to the standing version where you don't have to bend your knuckles as much, but you have confidence that you're activating. That's the key here is notice I said activation. Activation is important because people just don't activate their muscles well in the feet, in the toes, and in the lower abs and glutes. Did we get connected? I'll come back to the comments. Let me see if it was Ben, right? Ken, so sorry. Hey, Ken, are you with me? This is Dr. David. Let's see. Yes, I hear you now, Ken. Fantastic. Nice to meet you, Ken. How can I help you?
My question is actually more about the neck and back area versus the feet. I
Okay.
have an MRI that says C5, C6, mild disc space height loss with end plate degeneration, C6, C7, moderate disc space height loss with mild end plate degeneration.
Okay.
And I have more details than you would care for, but um, I am doing physical therapy. It seems like their exercises contradict what the exercise you have on your YouTube. So I just wanted to see what you recommend for the situation. Like one of your YouTube videos said, general physician said, "Well, you're getting older, so that's the way it is." And I saw one of your YouTube videos that you said that's not an acceptable answer. And then I saw a few of your physical therapy ones, and you said the exercises I'm doing in my actual physical therapy should be done. So, what is your take?
Well, from what you said about your MRI report, it sounds like maybe an X-ray report. That is a fixable situation in most people. When I say fixable, I mean if you have pain from that, it's usually possible to reduce or eliminate the pain as long as you can normalize the pressures in the area. The number one thing that I see with people that have X-rays like what you described or MRI reports like you described is they don't have enough strength in some key muscles. There's two key muscles in the neck specifically that people need to get stronger. One is the shrugging muscles, the upper trap muscles, and then in combination with that, the deep neck flexor muscles. The deep neck flexors are behind the throat. They're the ones that activate when you'll feel them. If you make a big double chin, like everybody who's watching right now, just make the biggest double chin you can, and you'll feel some tightening behind your throat. Those are the deep neck flexors. Those should kind of activate when you do any sort of shrug movement. When you have strength in these muscles, it normalizes pressures through your spine in your neck, and it prevents those situations from happening. So look at the neck here. The end plates are right above and below the discs of the neck. There's discs in your neck, just like in the lower back right here. And the shrugging muscles connect to every bone on the back of the neck right here. And then the deep neck flexors connect to the front of the neck. The deep neck flexors are kind of like the core, like the abs of the neck. They stabilize the neck. They're the deepest muscles. And then the shrugging muscles, the upper traps, are kind of like the glutes in the hips. They're like the glutes of the neck. And so they need to work together. When they work together well, and you're in the habit of using your shrugging muscles appropriately, like when you reach up, you should be. Have you heard about rule of the hand, Ben?
No.
I'm sorry, it wasn't Ben, it was Ken, right? Ken. So sorry. The rule of the hand activates the shrugging muscles and the neck muscles. The way this works is wherever your hand goes, your shoulder blade should follow. So if you're reaching up overhead, your hand's going up overhead, so your shoulder blade has the ability to shrug up as you reach up overhead. And what your neck and head should be doing is staying still. What a lot of people do when they reach up is their head kind of tilts or they look away. They do funny motions with their head, and that's because you have imbalances that don't properly stabilize your neck. But if you can keep your head stable as you shrug up to follow your hand with your shoulder blade, that's what should happen. So when you're thinking about exercises, you need to follow the rule of the hand. If you're reaching forward, your shoulder blade should go forward. Your shoulder blade has the ability to move forward. And if your hand goes behind you or towards you like this, then your shoulder blade should pinch backwards. That's the rule of the hand. And then all the motions in between. If you're reaching up at an angle, move your shoulder blade at that angle. That's that's an everyday movement thing that has to happen with your shoulder blade and your neck for you to normalize the pressures in your neck. This isn't taught in physical therapy for sure. They're gonna have you do neck exercises where you turn left and right, or where you're on a ball, they'll hang weights from your head. There's machines out there that have you move your head against resistance, and really those just feed into the problem because they're moving all the other muscles like this, the sternocleidomastoid, this big one right here. They'll strengthen that one, and that one doesn't. It's not the shrugging muscle, and it's not one of those deep neck flexor muscles that you activate when you do a double chin. That one's gonna add some bad forces to the neck. Did I answer your question, Ken, or was there did I miss something?
Right. So just should I they have you doing like neck stretches, like you tilt your head to the left and then you turn it down to your armpit
Mhm.
and maybe both sides. Would you agree with that method?
What they're usually after is stretching the very muscles I'm telling you to strengthen. So that movement right there is usually stretching the levator scap and the upper trap muscle. And here's the thing with stretching. Stretching on a low level for a long period of time weakens muscles. The thing is, if you feel like it helps you in the short term to do that stretch, like it relieves some pain, go for it, do it, because maybe it helps you avoid taking pain medication or visiting the doctor for an injection. That's okay, but we have to strengthen the shrugging muscle still. But I've seen a lot of therapists, I've seen a lot of, chiropractors, healthcare people on the internet showing people to do stretches for their neck, and it's not a bad thing. It's bad when it's the only thing you're doing. But it's a piece of the process. There's a process to fixing muscle imbalances, and that's done at the beginning when you're having some stiffness and some pain, and you just wanna relieve that stiffness and pain.
Now, I'm in my mid 50s.
Mhm.
How soon should you think I should get back to normal? Because I got pain going up and down my arm. I've got
Yeah.
tingling in my fingers. I mean, how long do you think doing these exercises that you recommend I would see some relief?
It's a difficult question to answer, Ken, because you it really depends on how severe the muscle imbalance is. And this is something that nobody else will tell you because everybody else will tell you that it's only gonna get worse. You know, you're in your 50s right now, what's gonna happen when you get into your 60s? They expect it to get worse with age, but they're not assuming that you're gonna fix the muscle imbalance. And the muscle imbalance, I don't know how to rate severity of muscle imbalances. Like it's such a new field or a new area that I'm talking about. There's no way to quantify it unless you were here and I can kind of tell you. And even then, it's like a based on other people that I've seen situation. It's not like you're a 10 out of 10 or a 2 out of 10. But if I had to give it a number like that, if you were a 10 out of 10 muscle imbalance severity, it's probably going to take you the better part of a year, maybe even more than a year. If you're a 5 out of 10, probably like 6-ish months. If you're a 1 out of 10 on the muscle imbalance severity, you're looking at like at a month or two. Like it's just that's how I would gauge it, roughly. But just realize that the severity of the muscle imbalance does not always correlate with your X-ray or MRI. You could have a terrible looking MRI or X-ray and your muscle imbalance isn't that bad. And the flip side, you can have a beautiful looking MRI with minimal stuff on it, and you can be in intense pain and have a severe muscle imbalance, a 10 out of 10 muscle imbalance. That's where it gets confusing because you're looking at what the doctors gave you, going off what the doctor said, and then I'm telling you there's a muscle imbalance. But what I would want to see is how well can you hold the shrug without your neck doing funny stuff. It's things like that that I would look at to begin to gauge how bad your muscle imbalance is.
Great.
Yep.
Great. Well, I appreciate the advice and guidance. Thank you very much.
Yeah, of course, Ken.
Great work here. Thank you.
Thank you. I appreciate that. Glad to help you out, Ken. Have a great day. Bye. I haven't had a neck question in a while. I love dealing with the whole body, by the way. Like I tend to help people with knee arthritis and hip arthritis, but I feel like I do great at back problems and neck problems, shoulder problems. I love to deal with wrist and hand, foot problems. Um, I love all that stuff, and I can help people in all those ways usually. So glad to have a neck question for Ken. Hopefully, I helped you out, Ken. All right, who's next here? We have Kimberly. Kimberly says, "Do you still have synovial fluid even after a TKR?" That's a good question, and I can't tell you with certainty, Kim. I my guess is you do because you still have a joint capsule, and the joint capsule will still generate fluid, but the parts have been replaced. Um, I don't know. Hard to know. The surgeon would have that answer for you. STF says, "I have been working on my glutes, but now sometimes I have pain in my glutes. Am I doing too much?" Probably. You can overdo a good thing. You can overdo it. Like with the tailgate swings, they're pretty low impact activity, but every now and then we have somebody who says, "I've been tailgate swinging nonstop for 72 hours, and now my knees hurt." And we tell them to back off a bit. You need to have some rest. Just like anything else. I mean, you might love cake, but there comes a point where you have too much cake and you don't want any more cake. So back off from the glutes. Take a break. Pace yourself. Belhart says, "This is making great sense." Fantastic. I love that. And Belhart, if you're not a medical professional, that just proves my point that this isn't complicated stuff. And if you can get it and you're not a medical professional, like I'm not trying to play games or talk about some complicated treatment approach. You see all these medical breakthroughs and there are these scientists doing creating these new procedures or they're researching chemicals in the body and making medications to combat them to help, gene suppressing medications for knee arthritis. They're looking at this very complicated stuff, and I really think that they're overcomplicating it. It's a mechanical problem nearly all the time. I'm not saying it's always that, but it's heavily a mechanical problem, and we're not researching the mechanics of it nearly enough as we should. So glad you're making sense of it, Valhart. Donna Cude says, "Does knee arthritis come and go?" Yeah, the symptoms anyway. There are lots of people that say I had a flare up for a month or two. By the way, if you can find whoever's moderating comments, if you can look up knee arthritis and Leslie Nielsen, you'll find the video. Maybe we can comment it here. And he says Leslie Nielsen is being evaluated by a doctor for knee arthritis. They're diagnosing him on this video. And he says, "I had it for 2 months." They even summarize. It's like a 4-minute video. It's not very long. Maybe it's 5 or 7 minutes. I don't remember, but it's not a super long video. he says on there it feels fine at times, and other times it feels bad. Like you guys have all had that experience where it comes and goes. It's not a it's unless it's been there for a long time or it's the muscle imbalance has flared up on you a lot, then it can become where it's a constant situation. But for a lot of people, it's off and on. Like it comes on for a week and then it goes off for a few weeks, maybe a few months. It comes and goes. 999 says, "Doctor recommended cortisone shot, every 3 months and steroid fluid injection every 6 months. What do you think?" Yeah, that sounds like a doctor plan. You're in the I erased it, but you're in the medication and injection phase right now, and then the stenoid fluid, probably synovial fluid injection, is like the like hyaluronic acid injection, a gel shot. They're trying the regenerative medicine with you. So you're on the normal pathway. You're on the conveyor belt of mainstream medicine where they're going to do the medicines, injections, probably physical therapy with the wrong kind of therapist, and then eventually surgery because it just keeps getting worse because the root problem was never addressed. So it's up to you. Just I'm fine with you going through that process as long as you know that's not going to solve the problem. It's just masking the pain. It's not making your glutes stronger. It's not making your lower abs activate or your toe flexors activate. It's not teaching you to walk with your glutes. So it's not going to fix the problem. But it might be okay for you right now, but I wouldn't rely on that forever. There's research that shows that the cortisone shots degrade your body, your connective tissue in your body. In the short term, it helps with the pain and inflammation, but inflammation is an important first step for regeneration of tissues in the body, for healing. You're killing the healing actually by taking the injections. And then the synovial fluid injections, the research is all mixed. The latest I heard is that they don't really make that they don't help that much. But there's some people that I've talked to that said that it helped them. So it's up to you. Just know that it's not fixing the root problem. Go fix the root problem. Get the glutes active. Do all this stuff here. 3 nines. All right, we got a multiple comments I'm gonna read here. Shukath, I'll just call you Ali. Ali says, "I had a distal hamstring tendinopathy injury after running 34 kilometers in December 2024. Went thrift, went through a lot of physiotherapy, strength training using isometrics, and restarted running on June 2025." Okay, so it's been a year. Then again in December 2025, I got knee bursitis in the same area. Never trained glutes until then. I have been inactive since the last 5 months. Now I restarted with just walking 30 minutes every day. Okay. But then I started to run walk for 30 minutes, like a 5K walk and 10K run repeat, or 5 minutes walking. It looks like intervals. Got re-injured again. What should I do now? Well, stop running for sure. That's making things worse. So we have another part. Currently taking anti-inflammatory and muscle relaxant medications for 2 weeks now. Started doing donkey kicks. Okay, now we're doing glute strengthening. Good. But the inflammation increased. Now I'm scared. Okay. Good. It sounds like you just ran with muscle imbalances, ran a lot. I've been there. I've done the same thing, Ali. Before I was aware of all this stuff, and yeah, you get all these running injuries as a result of it. I had a knee injury, a severe knee injury that I probably should. Oh, there's a Les Nielsen comment. Fantastic, the video. In case you guys want to see it sometime. Um, I had a posterior lateral corner injury, which potentially could have had surgery. I was able to heal from it naturally. I had to brace it. I had to go through the whole process, but I fixed my muscle imbalances. I can run now. I do runs weekly, several runs a week, and lift weights. I work out just about every single day, um, and I feel great. But tendinopathy, tendinitis, bursitis, strains, all those things happen as a result of muscle imbalances. If you don't go fix those muscle imbalances, you're going to keep running into problems like that. So the fact that you have been running like this, and even though you took a break, the break will just flare everything down. But if you get back to running with the same muscle imbalances, it's just a matter of time before it comes back again. There isn't anything special that's going to change. It's just going to take longer to come back potentially. It's going to relate to how much you run. So right now, do glutes. You're doing that. That's great. Work on your glutes somehow. I would want to make sure that you're activating your glutes properly. If the donkey kicks are working for you, because it's possible for you to do a donkey kick and really just use your hamstrings and not use your glutes, you're going to run into a hamstring injury again. You probably already have dominant hamstrings. So you need to go do lower level glute exercises. And it's tough, Ali, because you seem like the type of person that's intense about exercise. I mean, you go on some long runs. That's no joke. That's got to take you, hours to do. And so scaling back your exercise to seemingly very easy exercises that you could easily do might seem below you. I don't know, maybe you're okay with it, but I see this a lot. I went there myself. I was like, "Really? I gotta do these exercises? Come on, I could run for hours. I could lift hundreds and hundreds of pounds of weight." But it is necessary for you to get the right muscle activation and then scale it up, like do harder activities gradually. Because if you can walk with your glutes properly and then ramp up to walking and jogging with your glutes properly, then get up to jogging a few kilometers with your glutes consistently, then you can go to dozens of kilometers like you're used to doing. But it's going to take you a year, maybe longer. It took me a year to fix this problem. You're not going to fix this overnight. You're not going to fix this in a few months. I'll tell you that for sure. So if you want to use the medications, it's up to you, but you have to slow down to fix the problem. And sadly, Ali, I'm going to call you out here because you seem like a younger man, a younger male here who's doing this, and it's sometimes what's the right word? It's humbling to have to slow down. A lot of people don't. I see a lot of people your age. You look like you're in your 20s or 30s that are like, this guy's dealing with arthritis. People, I'm gonna keep running. And then years later, they're like, "Uh-oh, it's only gotten worse. There's no quick fix for this. You have to fix the muscle imbalance, and it's a long fix." But it allows you to have long-term, like, good quality of life, good quality exercise career, running career. Come on, Ollie, fix those glutes. Koki says, "I'm a gravel biker and am quad dominant. I always thought my glutes were strong, but evidently not in comparison." I'm glad you identified that, Koki. Yeah, that happens. It's tough to tell, especially if you're a more fit person, if you're active, like, you probably you see your glutes, you feel them working, maybe other people tell you you have, strong glutes or good-looking glutes, and you just have that assumption. But when you slow down and think, you put your hands on the muscles and you say, "Wait, can I fire my glutes without my thighs working?" If that's not working for you, then you're not in a position where you're gonna fix your imbalance, and it's probably why you have some knee pain. And cyclists and runners are very, very prone because you guys are getting thousands, tens of thousands of reps using the wrong muscles. Breathing space. Why did it take me weeks to be able to do tailgate swings? Even gently, it irritated both my meniscus knee and my healthy knee. Only now am I seeing the benefits, but I have to be consistent. It's hard to say breathing space. Sometimes I think that tibial shift might be an issue. Like if your tibia is shifted, your shin bone is shifted inwards, and you're doing the leg swing from there, it could be painful. And it's hard to tell, without seeing you in person. But glad you got some traction. Glad it's feeling better. You're getting the benefits now. Definitely stay consistent. And then I would work on activation. Like you should be able to do all these activation exercises that I showed you today to begin to get the right muscles active and then the walking. Good job. What else have we got here? Dr. Lyons, people are so judgmental when it comes to knee or hip problems. Other disorders are often invisible, but limping brings out the busybody in people arguing with armchair experts all the time. I know. Everybody's got their opinion. It's tough. I can't tell you, Dr. Lyons. I was at the store the other day, and I saw somebody walking through the parking lot. I saw two people walking through the parking lot. One was a youngster, a man in his 20s, had a knee brace on and was limping, visibly limping. And I'm like, "Guy needs crutches or something. Why is he walking with nothing? He could be healing so much faster." And then I saw an older woman who was holding on to probably her adult daughter, hunched over and was just limping so bad. And I'm like, "Why don't they just get the walker out? It would be so much easier." But I didn't talk to any of them, and I just let people make the mistakes and learn the hard way sometimes. But you fix yourself. You're here and you're learning this stuff. Apply yourself and be the example. When they ask you, like, "How'd you stop limping? How'd you avoid surgery?" Puts you in a good position to share. Breathing Space says, yes, I can do them all and walking now. Woohoo! Awesome. I still use one crutch, a lot of it just a pacifier at this point. Good, Breathing Space. That's fantastic. I'm glad that you're walking better and using all these muscles. So you're probably at a point now where you just need to strengthen, and it takes time to strengthen these muscles. You need to do more activation. Hold it for 10 seconds. Try to go harder with the toes, with the abs, with the glutes. Maybe even do some of the bridges I've talked about, or there's foot exercises and ab exercises I've talked about here on this channel. They're in our program, of course, as well. If you're a member of our program, you have all the videos and help to do those exercises. STF says, hi, Dr. David, knees are swollen. I walked also using my glutes. Am I missing out on something? Need help? Well, that's good that you have the coordination to use your glutes while you're walking. Awesome. Are you offloading? If you're swollen right now, you need to look at this chart and figure out how often is the swelling happening. Is it, let me get closer here. Is it this often, 4 to 7 days a week in the past week? Or is it this often? Or here? Or here? That's one way to figure it out. If your swelling is most of the week, you're in phase 1 and there's certain treatments you should be using. One of those might be the massage gun. One of those might be the offloading that I talked about. You have to do that stuff. That's how I built this process. It works. It's pretty consistent. It's good that you're using your glutes while walking, but you might still need to be offloading and using the glutes while walking. Use the crutches or a walker. Just because you have the glutes working doesn't mean you've graduated, because the swelling's still there. There's still something else happening, and you might need to just get weight off the knee to let it calm down. Hope that helps you, STF. Let's get that swelling down. Okay, you're gonna show 2 comments here? Oh, okay. So, Jeanette says, "Dr. David, can you tell us your thoughts on using a stationary bike? I've been diagnosed as bone on bone." And then somebody else asked about a recumbent bike. Cindy in Nova Scotia says, "Can I do recumbent bike? If so, how long?" Great. So, thoughts on the stationary bike for bone on bone. I think it might help if you can activate your glutes. That's the big part here. Glute activation is key. Like I would not go to bike. I did not list bike here on purpose. I listed walking. That was the first cardio type exercise that I listed. But you have to go through these things first to get to the walking and to get to the cycling. Whether you're doing a stationary bike or a recumbent bike, and the difference is the stationary bike is the seat and the pedals are stacked on top of each other, so the pedals are right under the seat. In a recumbent bike, the seat is and the pedals are in front, so you're reclining back. So it usually has a backrest on the recumbent bike. The upright bike or the stationary bike is there's no backrest. You're just sitting on a seat. The main factor that you need to put into the cycling, whether it's recumbent bike or upright bike, the regular stationary bike, is you have to have good glute activation. And what I mean by that, I'll show you over here. It's similar to the walking. When you're walking, every time you step on a leg, you're putting pressure. You should tighten up the glutes on that side, and then you alternate to the other glute when you step on the left side. So you're alternating glute contractions as you're walking. Well, it's the same thing as you're cycling. When you're pushing down on the pedal, it's like you're bearing weight on when you're walking. The glute should tighten up when you're pushing down on the pedal. The other leg's gonna come up naturally because you're on a bike. So when you push down with the left side, then the left glute should tighten up. So biking should feel like you're just alternating glute contractions. And what you should note as you're going through, whether it's recumbent or upright bike, is after a few minutes, like 2 or 3 minutes, definitely by 5 minutes, you should feel like some muscles are working, like something's starting to burn or warm up in your body. It should be the glutes if you're doing this correctly. If it's not the glutes and you feel like it's more thighs, like noticeably more of the thighs, then you're doing this wrong, and it's probably not a good thing for you to be doing. You need to practice it. You might need to just do it in spurts, 2 or 3 minutes at a time. Be very conscious about tightening your glutes as you push the pedal away from your body. That's the number one thing. Now, the medical field at large, doctors, physical therapists, praise and love the bike, and they just recommend it freely without any instruction, with 0 instruction on what muscles to use. They just say, "Oh, you have bone on bone knee arthritis. You want to avoid surgery. Well, before we do surgery, let's try to regenerate the cartilage with cycling. Go get a bike, or if you have a bike at home, get on it. And the theory is correct. The theory is that cartilage on the ends of bones right here, where you get arthritis on the back of the kneecap right here, it is healing is facilitated in cartilage when you do low impact movements and high repetitions, like with cycling, because you're not weight bearing, you're not standing, you're on a bike pedal, you put the resistance down, so you're not having to strain to push the pedals through. And so the theory is correct, and it might feel good even without using your glutes the first round of times you do it, maybe even for several weeks. The problem becomes when you start to work out your quads more because you feel good, you're biking, you're saying, I did 10 minutes, let's go 15 or 30 minutes or longer because it feels good. You loosen, you get the fluid moving inside your knees. It's kind of like a tailgate swing effect. But there's danger in you not using your glutes. You're feeding into the problem. You might get the problem that shows up weeks later. I see that consistently. So I'm okay with you using the bike. Just turn on your glutes. Be diligent about using your glutes in the bike. If you can use your glutes 8 out of 10 pedal strokes, you're good. It's not gonna be perfect, but if you can make it 8 out of 10, that's pretty good. And you're gonna feel better. CW says, but what about the quads on the bike? Okay. So I think what they're telling me is CW is saying, well, are you saying never ever work out the quads? Um, and here's what I'm not saying out loud. Let me say it out loud. You're using your quads anyway. Like on the bike, you're gonna use your quads. When walking, when you're doing the glute walking, quads are gonna work too. You just use the quads anyway, no matter what. It is impossible to completely shut off the quads. It's not possible, like unless you cut the nerve. But you don't want that. You need the quads. You need the quads. What we're just trying to do is offset the imbalance, make it a balanced muscle situation so that the pressures going through your knee joints are normalized, the normal pressures that your knee should take. The knee is designed to take some pressures, the right kinds of pressures. But when it's a lot of quad pressure, because those are the dominant muscles, the pressures are bad on the knee, and that's what sets up arthritis. What I want for you to do is to bias all your movements with the glutes. The quads will follow anyway. They'll still get a workout. It's just not gonna be the main muscle working out. And some of you guys are used to getting a quad workout. You judge the success of your workout based on how well you felt your thighs burn. And that's bad. You should judge it based on how well your glutes burn. You should go on a walk and say, whew, my glutes burned. And that's what you felt the most. You should get off the bike, stationary recumbent, and say, whew, my glutes burned. Quads, I felt it in my quads too, but my glutes definitely burned more than anything else. That's the feeling I'm after. You're not completely neglecting the quads. You're just biasing the glutes. Quads are still going to get a workout. This is an argument that I have with other healthcare professionals because they're saying, wait, you're saying never ever work out the quads? And what I'm saying is don't do exercises that bias the quads because then by default you're feeding into the problem. What I'm saying is focus on the glutes and you'll secondarily work out the quads anyway. But we don't need to focus on the quads because they're already dominant. If you can't activate your glutes today, you try to activate your glutes and quads just took over right away, we don't need to spend time on the quads. You're going to work out anyway. You're going to be fighting their dominance for the next several days, if not several weeks. You're going to work out the quads. We're not neglecting it. They're still going to work out. You're going to come along. Good question there. Good comment. Maria says, 9 months in, and the advice here is real and works. I got my life back 90%. I'll keep on listening to this team. God bless you. That's awesome, Maria. Thanks for letting us know. I love these comments. These just make my day. These just make it worth it for me. I appreciate that, Maria. Glad it's working for you. We're here to help you out, guys. We want you guys to do this stuff. And for those of you guys that are watching right now, you're thinking, well, maybe he sounds like he knows what he's talking about. Maybe he's right. Maria commented. We have all these other comments. And you haven't even tried this. What have you got to lose? You don't have anything to lose. You have so much to gain. Besides some time and some learning, what have you got to lose? You guys got to go check out our phase 1 for free. It is absolutely free on our website. if you go to the web page, and we've updated it a bit. There's the videos are free there for you, but I've even included for the knee arthritis recovery program. I have a free Kickstart program where I'll send you an email every day and give you bite-sized chunks of our free phase one. You get access. It costs you nothing. You just gotta sign up and put your details in there. And if you'll even get access to the quiz. We have a quiz that tells you what phase you're in, so that you can figure out what our phase chart here. I'll show you in a minute. So right there, this picture showing you the different phases. We have it all color coded. You can take a quiz on our site and figure out what phase you're in. Oftentimes, people start in phase one, they might be in phase two. There might still be a few things for them to learn. But if you go to our website, we have so many free resources for you guys. What I want you guys to take note of is our Kickstart program, though. This is new. You're going to start hearing about it more. There's a link. And this program, it's free. You don't have to pay anything. You just sign up for it. You just give us your email so we can, because we're going to send you emails, and we'll email you every day information about phase one for free. So you'll get all of phase one for free if you sign up for that Kickstart for the knee arthritis program. And that way you can begin our program and try it out and see if it's right for you, and hopefully get some help. You don't have anything to lose. It doesn't cost you any money, costs you some time, but you don't lose the time really, because you're gonna learn a lot. And if you do end up having to have a knee replacement, you're gonna learn how to protect that knee replacement later on. So it's a win-win. You can't lose. So if you're sitting on the fence and you're thinking, "What am I gonna do here?" Give it a shot, guys. You have so much to succeed with. All right, guys, that's it for today. Thank you all for joining me. I will be here with you guys next Tuesday. Please bring your questions, and I'm happy to chat with you. Let's get your knees feeling better. Have a wonderful week. Bye.